The title of today's lecture is Chronic Kidney Disease in Children, and I'm Dr. Shenal, Thalgahagoda, Consultant Pediatric Nephrologist at Renal. I've put down my email at the bottom of the slide for you to forward any queries or questions that you have after this lecture. So let's start with the definition. Chronic kidney disease can be defined as evidence of structural or functional abnormalities of the kidneys, which may be an abnormal urinalysis, abnormal biochemistry, or imaging studies, radiologically that is, or abnormal histology that persists for at least 3 months with or without a decrease in glomerular filtration rate. So this is basically the definition of chronic kidney disease, and we'll discuss it further as we move along. So how is chronic kidney disease classified? Well, there are basically 5 stages of chronic kidney disease in children. Stage 1 is where there is evidence of renal damage, which can be histological, radiological, or biochemical, as we discussed in the previous slide, going on for more than 3 months, but with the glomerular filtration rate being above 90 or the glomerular filtration being normal, and sometimes the glomerular filtration rate may be even increased in stage 1 CKD because of hyperfiltration. Stage 2 CKD is where there is mild renal damage and a mild decrease in glomerular filtration rate, with the GFR lying between 60 and 89. Stage 3 is where there is a moderate decrease in glomerular filtration rate, and the GFR falls to between 30 and 59. Stage 4 CKD is where there is a severe decrease in GFR. GFR has fallen between 15 and 29, and end-stage renal failure is or stage 5 CKD is where the GFR is below 15. So the units for GFR are in milliliters per minute per 1.73 meters squared, or the glomerular filtration rate is in milliliters per minute per 1.73 meters squared. So this is basically the classification of CKD, and we will discuss again the management according to the stages of classification later on in this lecture. So what is the etiology behind, what are the main etiologies behind chronic kidney disease in children? By far the most important entity in children are the congenital abnormalities, which are now called CACUT, or congenital abnormalities of the kidney and urinary tract. So these include posterior urethral valves, reflux nephropathy or vesicoureteric reflux, which we discussed during our UTI lecture, or dysplastic kidneys or renal dysplasia, which is a condition where the kidneys are congenitally not formed normally or hypofunctioning. So, the CACUT, or the congenital abnormalities, account for basically more than 80% of cases in childhood. Renal cystic disease, which includes autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. Recessive is more common in children, obviously. So these 2 entities also are important. A minimal portion or small portion of nephrotics do go into renal failure, especially the steroid resistant ones. So they also form a portion of the etiology. The glomerulonephritidis, especially the complicated ones, can end up with chronic kidney disease. Atypical hemolytic uremic syndrome is, or hemolytic uremic syndrome, even the typical form for that matter, can lead to acute renal failure. Familial nephropathies in the form of Alport syndrome, again another important entity in childhood, and any patient that has acute kidney injury and this persists
acute kidney injury also can lead to chronic renal failure. So a good example is snake bite. So a portion of patients with snake bite do not recover, and they move into chronic kidney disease. So these are basically the etiologies. Remember, the congenital abnormalities are by far the most important entity in children. This is as opposed to diabetes and the CKDU now in Sri Lanka in the adult population. Let's move on to pathogenesis. So what leads to the progression of chronic kidney disease? The first important entity here is called hyperfiltration injury. Now this can be described like this. So when part of your kidney is damaged, and when you've lost a certain amount of glomeruli, the rest of the glomeruli start hyperfunctioning, so that whatever blood is channeled through, say you have 1 million glom, you've lost 500,000, the blood flow is channeled through the remaining 500,000, and the intraglomerular pressure in these remaining glom is higher. So the more glom you use, the higher the intraglomerular pressure in the surviving glom, and this leads to increased intraglomerular pressure, and that intraglomerular pressure damages the glomeruli further. So there's further loss of glomeruli, further increase in intraglomerular pressure, and a vicious cycle is created. So that's why once you reach the advanced stages of chronic kidney disease, it is a relentless progress, and it becomes a progressive disease, and you end up in end-stage renal failure. So at some point, whatever you do, whatever management measures you undertake, the progression is relentless. So what you can do is try to minimize the progression, but eventually these patients will end up in chronic end-stage renal failure. Hypertension basically causes further renal damage. It increases hyperfiltration injury, it drives hyperfiltration injury, and it increases intraglomerular pressure, and thereby causes further glomerular loss. Proteinuria causes glomerular sclerosis. So again, proteinuria leads to loss of glomeruli, and the same process comes into being. Hyperphosphatemia and hyperlipidemia, both because of the vascular changes that ensue, lead to progression of chronic kidney disease. So the pathogenesis of chronic kidney disease is important, because manipulation of this process of progression is what we basically aim at when we try to slow the progress of chronic kidney disease. Right. How do these patients present, or how do patients with chronic kidney disease in childhood present? Firstly, they can be asymptomatic, and they can be found to have biochemical or radiological or hematological abnormalities when they are investigated for some other entity. They can be found to have proteinuria 3+ proteinuria. They can be found to have bilateral hydronephrosis and hydrouretas indicating reflux. They can be found to be anemic, and when you investigate for anemia, you can find chronic kidney disease. So they can be asymptomatic renal wise and be detected thus. Anorexia and lethargy are very important features of presentation for chronic kidney disease, because urea or uremia causes severe anorexia and lethargy. Polydipsia and polyuria are also very important entities. These patients, a lot of patients with chronic kidney disease are polyuric, especially the ones with dysplastic kidneys. This is as opposed to acute renal failure, where we said that most patients are oliguric or anuric, and they can even present with secondary nocturnal enuresis. So one of the investigations that you need to do in a patient presenting with nocturnal enuresis secondarily, a patient who's been continent presenting with secondary nocturnal enuresis, you need to see whether the patient is in renal failure actually. Failure to thrive and short stature are very important in children. So one of the one of the workup investigations you do for a patient with failure to thrive, and for that matter for a patient with short stature, is a creatinine to see whether he is in renal failure. They can present with the bony abnormalities of renal osteodystrophy. We've had patients, several patients, who have presented with features of rickets, and they've been on investigation for rickets. They've been found to be in renal failure. They can present with what is called acute and chronic renal failure. So a patient who's known to have chronic renal failure can present with an acute exacerbation due to maybe an infection. It's a patient with reflux, recycled reflux, can present with a decompensation due to severe pyelonephritis. Hypertension is another mode of presentation. So patients on investigation for hypertension can be found to be in renal. You have evidence of CKD, and we've discussed this already. Previous acute renal failure is a mode of presentation for chronic renal failure. So what are the investigations you do in these patients? A full blood count and a blood picture would denote anemia, the anemia of chronic kidney disease. We'll discuss this later. The blood urea will obviously be elevated. Serum creatinine will be elevated. Serum electrolytes, you can get hyperkalemia in patients with CKD, but that usually occurs in the later stages of chronic kidney disease, as opposed to acute renal failure, where it can be an early feature. Sodium may be high or low depending on the presentation. Calcium and phosphate and alkaline phosphatase, or the bone profile, is an essential investigation you need to do in patients with chronic kidney disease. We'll discuss this as well later on when we deal with renal osteodystrophy. And the parathyroid hormone level is also an important investigation that we do, because the parathyroid gland is hypersecreting, or you get an elevated PTH. So we'll discuss this further when we deal with the renal osteodystrophy. Another investigation that you need to check is the venous blood gas, because one of the features of renal failure is acidosis. If the patient has a proteinuric state, you need to do the albumin cholesterol. You need to do the albumin, the serum cholesterol level, the urine full report to see whether to look for proteinuria mainly, and you need to do a serum ferritin level every 3 months just to see the iron status, because these patients can be iron deficient as well, mainly contributed to by the fact that they have severe loss of appetite. So apart from the anemia of chronic kidney disease, they can have iron deficiency as well, and they can be anemic for that reason as well. And you need to do the lipid profile to see that the there are no lipid abnormalities, because as we mentioned, abnormal lipid status drives the progression of CKD. So basically, what are the investigations you would do? Basically, look for the derangements that occur in renal failure. So if you know the functions of the kidney, basically you are testing what functions are abnormal, and the choice of investigation basically is testing the deranged renal functions. So if you remember your renal functions, your physiology, the renal physiology, it is easy to work out what investigations you need to do. So investigations, as I said, are basically testing what functions of the kidney are abnormal. So how do you calculate what is called the estimated glomerular filtration rate, or the estimated GFR? In pediatric practice, we use what is called the Schwartz formula, which is calculated thus. So you have a constant, you multiply the constant by the height divided by the serum creatinine, and remember the height is is obviously in centimeters. The serum creatinine has to be in milligrams per deciliter, and the value you get is in milliliters per minute per 1.73 meters squared. So your GFR, or the glomerular filtration rate, is calculated basically based on your height and serum creatinine. This K value, or the constant value, is 0.33 for low birth weight infants less than 1 year, 0.45 for term normal birth weight infants, that's less than 1 year, 0.55 for all children and also adolescent females, that's above 12 years of age. So all females are calculated at 0.55, and it is 0.7 for adolescent males. So males above 12 years, the constant is 0.7. In our ward, in our setup, creatinine is measured in micromoles per liter. So you need to divide the micromoles per liter, the value attained by through micromoles per liter, by 88.4 to get the milligram per deciliter values, because that is the value you need to apply in Schwartz formula. So Schwartz formula is basically a bedside calculation based on the height and GFR to calculate. So all you need is the patient's height and the serum creatinine value, and you can calculate the patient's estimated GFR. And it's quite accurate, and it's a very practical test that we use on a day-to-day basis in the ward. So it's very important that you know this formula when we come for your clinicals. So what are the management concepts? We'll discuss these based on the stages of chronic kidney disease that we discussed in a previous slide. So as I mentioned, there are 5 stages of chronic kidney disease. So in the early stages, that's in stage 1 where the GFR is above 90, and in stage 2 where the GFR is between 60 and 89. What you're going to do, or what you need to do, is to look for the etiology. Why is the patient in chronic kidney disease? So you can do ultrasound scans, you can do your biochemistry, you can do your you can do a renal biopsy, or look at the histology, basically trying to establish why the patient is in chronic kidney disease. So you look for etiology, and you need to apply the renal protective measures. These measures we'll be discussing in a subsequent slide, where we apply measures that protect the kidneys and prevent or slow the progression of chronic kidney disease. So these renal protective measures are not only applicable to stages 1 and 2, they're applicable to stages 3, 4, and maybe to a certain extent in stage 5 as well. Right? So these are also extremely important because, as I mentioned previously, chronic kidney disease is a progressive condition, and renal protective measures slow that progression. In stage 3, when the GFR falls to between 30 and 59, that is the stage at which where your biochemical and hematological derangements start manifesting. So you can get your acidosis starts to appear, renal osteodystrophy starts to appear, the anemia of chronic kidney disease starts to appear. So you need to start correcting the deranged hematological and biochemical parameters in stage 3. In stage 4, once the patient reaches stage 4, that is when the GFR falls to between 15 and 29. That is the stage at which you need to prepare the patient for transplantation or dialysis, because at some stage this patient is going to go into end-stage renal failure, and that is a certain fact. So you need to prepare the patient for transplantations. You need to start looking for a donor and start working up or preparing the donor so that you can transplant the patient when the patient is at the stage where he needs a transplant. If there is no donor, you need to start preparing the patient for dialysis. So you need to decide on your mode of dialysis, whether it's going to be peritoneal dialysis or hemodialysis. And if the patient is choosing hemodialysis, you need to discuss vascular access and try and get a fistula in. We'll discuss these later. And you need to prepare the patient for either transplantation or dialysis. When the patient moves into stage 5, that's when the patient needs renal replacement therapy. So stage 5 is where the GFR is below 15, but you don't have to commence dialysis usually as the patient as the patient's GFR falls to below 15. Usually you can wait a little longer if the biochemistry and the other parameters are stable. The usual average GFR at which dialysis is commenced is around about 8 to 10 milliliters per minute per 1.73 meters squared. Transplantation, if the patient is ready for transplantation, transplantation can be done when the patient reaches stage 5 CKD without dialyzing the patient. You can straight away go for a transplant, which is called a preemptive transplant, where you transplant the patient before dialysis. So these are basically the management concepts based on the stage of CKD, and it's very, very important that you grasp these concepts. So what are the overall aims of management? I've mentioned that we need to slow the progress of CKD. CKD is a relentlessly progressive condition, especially in the later stages. So we need to apply whatever maneuvers are possible to slow the progression. You also need to correct the deranged biochemistry and the hematologic and the deranged hematology. You need to correct your anemia, you need to correct your acidosis, you need to correct the renal osteodystrophy as far as possible. And an important entity in children, which is not obviously applicable to adults, is that you need to maintain normal growth and development as much as possible. It's very difficult, but you need to try to do what is possible to maintain normal growth, because otherwise if you don't address the growth, these patients will have a transplant. If the growth fails, they will have a transplant, and if the transplant is done after puberty, they don't have potential to grow following transplantation, and they will remain extremely short, which is a major physical barrier later on in some of these patients. So you need to do as much as possible to maintain normal growth. And in other countries, well, it's coming in Sri Lanka as well, the use of human growth hormone also has been utilized for chronic kidney disease. So what are the management? What do we need to manage in patients with chronic kidney disease? We need to manage the anemia. We need to manage the metabolic bone disease. We need to control the acidosis. We need to control the hypertension. We need to manage the fluid and electrolyte status. We need to manage growth, and we need to maintain proper nutritional status in these patients. And eventually we need to prepare them for renal replacement therapy.